Okay, here we have the module on ADHD. So we're going to go through these medications fairly quickly because there's not a whole lot of medications used to treat it. So we're going to skip through the diagnosis and symptoms of ADHD because you get that in your other classes. But treatment of ADHD for patients who are truly have ADHD is very important. A lot of times, treatment doesn't. If the symptoms persist into adulthood, treatment does not also continue into adulthood. So that needs to be looked out for. There are plenty of patients who no longer need treatment as they reach adulthood, but don't just assume that, okay, well, they're getting older, they're not in school anymore, so they don't need medication. Your treatment options are medications. You're going to first line use stimulants, and these stimulants, there's basically two categories. There's methylphenidate, and then there's amphetamine salts. And all stimulants are derivatives of those two medications. There's no difference in effectiveness, and the only difference in different medications is how long they work and how quickly they work. Second line, which we'll talk about after the stimulants, is atomoxetine or Strattera, bupropion or Wellbutrin, and then you have TCAs. And there's also adjunctive therapy, your alpha 2 agonist, which are most commonly seen, and then rarely you'll see the antipsychotics, anticonvulsants, and lithium. Usually that's if they also have other psychiatric disorders to go along with it. So the pharmacotherapy of ADHD treatment is focusing on the stimulants increasing norepinephrine and dopamine to improve efficacy of processing, to help improve the symptoms of inattention, impulsivity, and hyperactivity. Stimulants are very effective, the effective rate of 65 to 75%. Methylphenidate and amphetamines are both equally efficacious, and there's no way to predict which one the patient will do better on. Basically, you pick one based on other reasons, so it might be based on cost. I believe that methylphenidate, regular methylphenidate, Ritalin, is I think fairly inexpensive in a retail pharmacy. Or it may be that insurance covers one and not the other, or that they have a sibling who did really well on an amphetamine derivative, and not so well on methylphenidate. So that kind of gives you a direction to go in. So you pick one. If they don't respond or as well as you would want, then you switch. If treatment failure occurs, at a therapeutic dose, then you would try after both stimulants. Then you would move on to second line treatment options. And we'll talk about those afterwards. So there are non-pharmacologic treatment options, which I would recommend. They're not as popular, obviously, as medication because they take time, money, and you have to do them routinely as opposed to taking a medication every day to solve the problem. But there are family-focused interventions, school interventions, classroom management, tools you can help teach the child to help, especially once they get into like middle school, high school, that they can use to help focus. And then cognitive behavioral therapy is helpful also. So all stimulants are Schedule II controlled substances. So you're limited to a 30-day supply with no refills for each prescription, and they expire after 90 days. This slide says cannot be written by nurse practitioners. I know that varies by state. I think in South Carolina now in South Carolina, nurse practitioners can write for Schedule II stimulants, but they have to be a maintenance. They cannot initiate Schedule II stimulants. So if a patient's already been on Adderall 30 milligrams, one tablet twice a day, the nurse practitioner can write that can write that prescription because it's a continuation of a previous order from a physician. They're not allowed to change doses, change frequencies. and initiate the therapy for someone who's a newly diagnosed ADHD patient. But double check your state's guidelines, because they do vary by state, and even the here in South Carolina, that the stance, at least on the pharmacy side, is that if we get a prescription from a nurse practitioner or a PA for these things, um, uh, then it's not it's not, the pharmacist is not going to check and see if it's a continuation of therapy. That's between you and your accrediting board, and they will make, they have the final say in it. So they'll have the regulations that you need to follow. So your stimulants are methylphenidate and amphetamine salts. Both of them block dopamine and norepinephrine and inhibit MAO. Non-response just means you would switch to the other one, and you'll probably have a better response with the other one. Pharmacokinetics for methylphenidate. So methylphenidate is, from here on, we're going to kind of separate out the different products under methylphenidate and then under amphetamine salts. And where they differ is how fast they work and how long they work. So do you have somebody who needs multiple tablets a day because that helps them better? Do they want a continuous release one, which may work for, you can have some that work for 8 to 12 hours. So then I can take one in the morning and it holds me all day, and then it's wearing off by the time I hit dinner time, or I no longer need the medication, and then I'm able to go to sleep, because they're stimulants. They're gonna make patients. It's gonna make it hard for patients to fall asleep. So we'll go into each one and kind of briefly talk about the differences. Again, none of them work better than the other one. It's just a way to target when the patient is having the most symptoms and how it works in their day. It might be too hard for a patient who's going to school, that their school doesn't allow medications to be brought in, so they can't take a lunchtime dose of Ritalin, so they need a controlled release version to last, a full 8 hours. But then we want it to wear off when they go to their after school activities, so that they're just playing, and we don't really require the attention treatment. So methylphenidate is the immediate release original version of methylphenidate. It's generic. It's been around for a long time. And the duration, again, depends on the formulation. So immediate release formulation, so just Ritalin, is usually given twice a day before breakfast and lunch. There are long-acting versions, so methylphenidate LA for long-acting, or methylphenidate CD for controlled delay, I think is what. But CD, LA is best suited for if you have severe morning symptoms, because there's a large immediate release percentage in there. So you kind of get a bolus dose in the morning of the immediate release, and then you have some controlled release later on throughout the day. So it's actually two different formulations in one capsule. The CD, methylphenidate CD, is better suited for rebound afternoon symptoms, because there's a larger extended release ratio. So that's kind of where each one has its benefits. You also have the methylphenidate OROS, which is an osmotic release system. So basically, water goes into this tiny pill that's had thousands of holes drilled into it, and it pushes out the drug at a continuous release throughout the day. This is a good version if this is Concerta, so it's effective because it's kind of a continuous release all day. And you can see here, there's kind of a conversion of Ritalin, methylphenidate IR dose, to Concerta, for the day. So if your patient is doing well on 10 milligrams 2 to 3 times a day, they're doing really well on that, but now they're in a situation where they can't take it 2 to 3 times a day, or maybe they now have insurance coverage and they want to go to the Concerta the once a day because it is more expensive. Then you could switch them to the Concerta or methylphenidate OROS 36 milligrams daily. So that one is more of a sustained release versus these LA and CD, which kind of have peaks and waves in there for morning and afternoon symptoms. And then methylphenidate transdermal patch, they don't have an equivalent dose to oral methylphenidate, but it is an option for patients. I don't believe the insurance coverage is very good because usually transdermal administration is more expensive than oral, just in general, and I don't think the insurance is going to cover it very well. So, Ritalin or Methylin is the immediate release version. You can see here each of these slides kind of breaks it down into what to know about that specific drug. I'm not going to read each one because it's fairly straightforward, but just a few points on each one. Ritalin and Methylin, the big takeaway is you want to take the last dose before 6 p.m. if the patient has difficulty sleeping. Most of the times, if it's given 2-3 times a day, you're going to get before breakfast, before lunch, and then kind of mid-afternoon, maybe that end of the school day kind of dose. Focalin is another extended release dexmethylphenidate, so it's a chemical isomer of Ritalin. I won't get into the whole chemical structure, but it's basically, let's say it's a more potent methylphenidate, but it's given at half the dose, so it's really not a whole lot of benefit over Ritalin or Methylin. It's still dosed twice a day, and again, because it's an immediate release, you want to give it at least before 6 p.m. To prevent difficulty sleeping. Ritalin SR, Metadate, and Methylin ER. This is a sustained release methylphenidate. So it's going to release through the tablet, from the tablet at a more sustained release. You can dose it once a day because it has an 8-hour duration. So, but you can do it twice a day if needed. So if you have a child who has an 8-hour school day or only needs 8 hours of coverage, you could give it once. But let's say you once they get older and you have an adult who's on it who works 10 to 12 hour shifts, then you could give it twice a day to cover the extended needed duration. And you're going to see this for the most part with all of your medications that treat ADHD. We're not treating the times of day they don't need the attention, the symptom control. They don't need it at nighttime. They don't need it when they're playing. A lot of times kids will kind of take breaks. You can have them take breaks in the summer from the the ADHD the ADHD medications. Their parents may not like that as much because then they're at home during the summer and symptomatic. But you can have them take breaks, or if they're Christmas break, spring break, those kind of things. We're only treating when we need to treat those symptoms. It's not like blood pressure where we're trying to have 24-hour coverage. One thing with the sustained release, if you're giving it twice a day, you want to give more of the dose as the first dose, and then the second one's just kind of an addition. At the end of the day, that would mean that there'd be 2 prescriptions for that, and that could get expensive. So, do the best you can, but just know that if you give a higher dose as the second one, it may prevent them from being able to sleep. Focalin XR is where we're getting into the extended release versions. It is always a once a day medication. And one thing to note is the capsules may be opened and sprinkled in applesauce if they're unable to take the capsules. I think even since we started this class, I think another methylphenidate has been released. There's been a big push recently to have other dosage forms, like we talked about that patch earlier. I think there's now liquids, and I wouldn't be surprised if we get into like gummy methylphenidates, and there's chewable tablets, I think. So everything may not be included in this, but they are focusing on, I guess, for patients who don't want to take tablets. We're having some of those. They're either in phase 3 trials or they're about to start production. So if you see those, just make sure you're looking at, okay, what is it kind of comparable to? Is it the ER where I do once a day? Is it Ritalin, which I do 2 to 3 times a day? So you know kind of how long it should work for a patient. Ritalin LA is very similar to Focalin XR. It's an extended release, and it can also be opened and put into applesauce. Again, with Metadate CD, these are all just different companies who have all come out with an extended release methylphenidate. They are very, very similar to, to it. You have, slightly different amounts of, or slightly, you may have, let's say a patient does really well on Ritalin LA, but you want to try see if they can get a little bit more symptom control, then you might switch to, say, Focalin XR or Metadate CD. But for the most part, they're going to be similar for all the patients. Concerta, very popular methylphenidate. It's an extended release. It's given once a day. It may be taken with water, milk, or juice. You have to take it with some kind of liquid because it's an osmotic delivery system, and the drug is released at a controlled rate. So actually the fluid's going into the capsule, into the tablet, and pushing it out the holes, microscopic holes drilled into this tablet at a controlled rate, based on the size of the molecule and the size of the hole. Now, what some patients don't see is that capsule you can't have a ghost tablet come out in your feces because it may not be dissolved all the way. So that's something the pharmacist will counsel the patient on. That just because if you see the capsule doesn't mean it didn't work. All the drug has come out of, I keep saying capsule, but it's shaped like a capsule, but it's actually a tablet. But they may see it, but it's not one. They don't have to worry about the effectiveness. Daytrana is an extended release methylphenidate patch that is, excuse me, applied 2 hours before you want the effects to start, and you can wear it for up to 9 hours. The drug will still have an effect for 3 hours after removal. So knowing that, if the patient wants to you have to, I got to go to bed early tonight because I need to be well rested. Well, then they just take the patch off at least 3 hours before going to bed. That way, the drug can work its way out of your system, and you can go to sleep. This also might be a good patch for people who they know that they don't want any medication after. I just need to make it through the work day, and my work day's done at 5, so I can take the patch off at 3 o'clock, and I have the effect is going to work to about 5:30 or 6. So I know that it's only going to be in my system for when I need it. And here's the administration tips. Patch is applied to a clean, dry area. Alternate sites and avoid the waistline because the pants rubbing it and it will affect the absorption. Avoid heat because that'll increase the rate of absorption, and the patches should not be cut to get a lower dose. So here's a list of methylphenidate containing products. This is not all inclusive because there have been some more to come out since this class started. There's several of these I've never used before. Some of these multi-layer beads and things, but basically you want to start at methamphetamine immediate release and going down to extended release options, because make sure it works for them. But first, and then try to find the one that fits their daily needs for the medication. And then you can, because they also get more expensive as you go up to Concerta and the Aptensio and all these. They get more expensive, and insurance may or may not cover it, because most of them will cover like one extended release version of methylphenidate. Even though there are technically some differences in all these, they'll cover one because that's what they're required to do. So start with the methylphenidate IR and then work your way down to fit it around the patient. Amphetamines are very similar to those. You have twice a day immediate releases or once a day extended releases. Adderall, we're all familiar with Adderall. Last dose given no less than 6 hours before bed, just like methylphenidate. Dextrostat is another immediate release dextroamphetamine. Dexedrine is a sustained release, just like the methylphenidates had, with an 8-hour duration. You're going to see that these mirror your methylphenidates. Capsules, Adderall XR capsule can be opened and sprinkled in applesauce, just like the Metadate was. Vyvanse is very popular dextroamphetamine. It's a lisdexamphetamine, so it's a prodrug, so it's rapidly converted. And once it's in the bloodstream, it is not more effective than amphetamine. It is more popular because of its once a day dosing and its kind of sustained release throughout the day. Also, the capsule may be opened, dissolved in water, and consumed immediately. So that does make it easy for people who don't like to take tablets to use. Liquad is a short-acting amphetamine salt that is liquid. And then you have all these other versions that mirror your methylphenidates in their duration and their time to efficacy, if they're a patch or an ODT, things like that. And the treatment with these is the same as methylphenidate. Start with Adderall, start with the immediate release, and then work your way down to the one that fits the daily flow of your patient. Contraindications, cardiovascular is a big one. You have patients who are symptomatic or have moderate to severe hypertension, cardiac arrhythmias, and recent MIs. Other contraindications, hyperthyroidism, glaucoma, history of abuse during or within 14 days of an MAOI, and any patient who has hypersensitivity. Adverse effects, you're going to have reduced appetite and weight loss. So what a lot of patients will do, and recommended, is to eat a high calorie meal when the stimulant's effects are low. So if you're going to take a controlled release tablet that works 8 to 12 hours, eat a high calorie breakfast, because they're probably not going to eat much for lunch. Or if they take the medication during the day and just make it through school, then have supper be their biggest meal of the day. So work around that lack of appetite for lunch. Stomach ache, usually when starting out, like any medication, take it with food and you'll be fine. Insomnia, you can alter the times of day that the patients are taking it, and to work around that. So stimulants and growth suppression. This is one that we have seen talked about with reasons people don't want to go on stimulants. The data is very controversial on this. There were 2 reviews of 32 studies that found that stimulants may affect growth, but the effects are minimal or insignificant for most children, and they lost 1 centimeter over the first year. So, or 1 centimeter a year of what they could have grown. So, height and weight should be measured at least semi-annually. One, to make sure they're growing on the right height track, and then weight to make sure that they are eating enough, and to get around those side effects. One way to get around this is what may be recommended is to do drug holidays. So for the patient not to take it when they're on Christmas break, on the spring break, during the summer, or to that way they you can have you can decrease the effects on growth if it is going to happen. So drug interactions, obviously you'll have additive effects for other psychostimulants, not within 14 days of MAOIs. Acid suppressants will increase the absorption of methylphenidate and amphetamine, and opioids can increase the concentration of amphetamines. So what do you want to monitor? Baseline every 3 months, or at least every 6 months. Blood pressure, pulse, height, weight, eating patterns, and sleep patterns for your patients, just to make sure nothing's changed. So non-stimulants for ADHD, what's approved is atomoxetine or Strattera, clonidine ER or Capvey, and guanfacine ER or Intuniv. Non-FDA approved, but they show efficacy as clonidine immediate release, guanfacine immediate release, bupropion, and tricyclic antidepressants. So the benefit of the clonidine ER and guanfacine ER is you can take it once a day as opposed to 2 or 3 times a day. That's it. That's what you're paying for, versus probably $10 a month versus $150 a month. It's just the number of times a day you're taking it. And those drug companies paid to have FDA trials done. That's it. So atomoxetine is the first non-stimulant approved for ADHD. It is a selective norepinephrine reuptake inhibitor. So similar to our antidepressants, but only works on norepinephrine. There's no abuse potential. It's not a controlled substance, so that might be a good option for your patient who has issues with those. You can see the dosing here. It's based on weight. You're going to administer it with or without food. Do not open the capsule. It does take 2 to 4 weeks to take effect. So that's something a patient needs to be reminded of, especially if they've had methylphenidate or amphetamine earlier, which starts working with the first tablet. And it may be combined with a stimulant for partial response. Now, contraindications. Think of this kind of as an antidepressant. So cannot use it within 14 days of an MAOI. It can cause narrow angle glaucoma or worsen it in patients who have it. Current or prior history of pheochromocytoma and symptomatic cardiovascular disease, which makes sense because we're increasing norepinephrine. Black box warning, increased risk of suicidal ideation in children and young adults, just like our antidepressants. There's a potential for severe liver injury, and priapism has been reported in children and adults during prolonged exposure or at a dose increase. So watch out for that. Common adverse effects, it's pretty well tolerated. They're similar to antidepressants. Your alpha-2 adrenergic agonists listed here, less effective than stimulants or atomoxetine or bupropion, but they can be used in adjunctive treatment to lessen the disruption in behavior, aggression, or help improve sleep. They presynaptically decrease, so their mechanism of action, they're an alpha-2 adrenergic agonist. So it works, enhances working memory and executive function. You can see the dosing here, fairly straightforward for clonidine and guanfacine. And the benefit of guanfacine ER is that it is a once a day dosing versus a 2 to 3 times a day dosing with the other ones. Side effects, dose-dependent sedation, rebound hypertension with abrupt discontinuation, and then cardiac abnormalities. Onset of symptom control can be seen within a week. Maximum effect within 2 to 4 weeks, so it is going to take time compared to your stimulants. Wellbutrin, you can see here that it can be used for it. It's going to have the same contraindications and side effects as if we were using it as an antidepressant, and same with tricyclic antidepressants. I don't see this used hardly ever for ADHD just because we have other options, and the side effect profile is not great. Some alternative options are polyunsaturated fatty acids may help. Iron supplementation for patients who are low in iron. So you can check for those, try those for patients. There's no good evidence, but nobody's really studying those closely because they're not prescription products. So it's going to have a harder time getting that evidence. Nerve stimulation for ADHD. I believe this has hit the market. That's indicated for patients 17 to 12 years old who are not on ADHD medications. Intended for home use during periods of sleep under supervision of the caregiver. It's a small phone-sized device connected to a patch on the forehead that delivers low-level electrical pulses. You can see the side effects there, and it's not used for patients with an implantable pacemaker or body-worn device such as an insulin pump. So, have not seen one of these used yet, but there may be a patient out there who's who would need it. So one thing I like to add before we finish up is that ADHD meds for patients who have ADHD are tied to lower substance abuse risk in those patients. Whichever it may be, whether it's a stimulant or it's atomoxetine, when the patients are followed, they have a lower risk of substance abuse. So that it kind of shows that why we need to treat this disorder even into adulthood, if the patients are still symptomatic and need treatment, because obviously their patients will have to have some kind of, if we don't treat it, they may self-treat, and that's the issue we get into. In the near future, we are looking at there is a medication, dasatralene, which is a dual dopamine norepinephrine reuptake inhibitor that has been submitted to the FDA. Studies look decent. It is a long half-life medication, so once a day dosing. It's going to be similar. I would see it fitting in kind of where Strattera is in the right after stimulants. I could see that being effective. I would like to see it versus Strattera, but we probably wouldn't see that study in a long time. Like, what's the benefit of the norepinephrine and dopamine versus just norepinephrine of the atomoxetine? So in summary, stimulants are first line. Strattera can also be a first line for some patients if they want to avoid stimulants. Wellbutrin and alpha-2 agonist second line, and if the patient doesn't respond to one, then you would switch to another class, another stimulant class before moving on and having classifying them as treatment failure.